I'm going to be introducing my colleague here. Dr. Harry Kim is a orthopedic surgeon here at Scottish Rite Hospital for Children in Dallas, Texas. He's the director of Center for Excellence in Hip Surgery. He is also a professor at UT Southwestern. He obtained his medical education at McGill University in Montreal, where he graduated with distinction of University Scholar. He completed his orthopedics residency at University of Toronto and his pediatric orthopedic fellowship at Hospital for Sick Children in Toronto. He's published numerous articles and book chapters on pediatric orthopedics, and his interest is particularly in Perthes disease. He is the chair of the International Perthes Study Group, and he's going to be giving us a talk today on Perthes disease. So Harry, you can go ahead and take over from here.
Great. Hey, thank you so much for that introduction, and also giving me this opportunity to speak about Perthes disease, which one of the diseases that I have like a very high passion, just because of the controversies, and there's so much to be learned and so much we could do to try to improve the treatment and understanding of the disease. Just a little information about the International Perthes Study Group. It's a group of pediatric orthopedic surgeons from all over the world, mainly from the United States and Europe. And our purpose is to study Perthes and find the best treatment. If you're interested in it, we're at the website perthesdisease.org. Okay. All right, so we're gonna move on to the next slide. So in terms of disclosure, I don't have many other than I have patents on device and methods for treating osteonecrosis, but I'm not gonna specifically speak about this. So just to give you a background on where I work, this is the Scottish Rite that opened in 1921. So if you do the math, we're on 100-year anniversary this year. So it's a big celebration. We have a relatively large surgical staff. We have about 22, I think, pediatric orthopedic surgeon that covers all subspecialties. And I specialize in pediatric hip disorders, specifically avascular necrosis of different kinds, including Perthes disease. We do have another campus now, 25 miles up north, just because of the population growth and demand. And one distinction about our hospital is that we do write the textbook, the Tadgens Pediatric Orthopedics. All right, in terms of things I'm going to speak with you about is, I'll just give you a brief introduction to Perthes disease, followed by pathophysiologies and stages of the disease, diagnosis, treatment-related considerations, and then role of perfusion MRI. So when I say perfusion MRI, I'm referring to contrast-enhanced MRI with subtraction imaging. So just to start off, you can see this gray-haired man. This is Dr. Stuart Weinstein. He's a very well-known pediatric orthopedic surgeon. And he says this about Perthes disease: it remains one of the most controversial topics in all of pediatric orthopedic surgery. And the debate about its etiology and pathogenesis continues, and there's no unanimity regarding treatment. So I put this slide just so that you know you are entering to the realm of confusion as well as controversy, so be warned. So in terms of terminology, I'd like to just define osteonecrosis, bone death, or necrosis. It doesn't really say anything about the etiology. So when you say avascular necrosis, then it specifically refers to osteonecrosis secondary to vascular disruption. So this could be due to traumatic dislocation, fracture, or idiopathic. So in case of Perthes disease, it's a juvenile idiopathic ischemic osteonecrosis of the femoral head, and you could also say avascular necrosis because there is disruption of ischemia. The thing about Perthes is we don't know what is causing this ischemic event. So just history, Perthes, the reason why it has three names, Legg-Calvé-Perthes, is because these three physicians who described it about 110 years ago. And from the outset, you can see that there's controversy regarding what the etiology and process it was involved. And you can see some thinking it was trauma versus abnormal osteogenesis versus inflammatory process. So one of the important things about Perthes disease is it's uncommon. And what that means is when it's uncommon, people are not familiar with it. And you don't see this every day. And that's why I think there's a lack of understanding as well as consensus on how to treat it, because we don't really have a lot of experience. And that's the issue with single center-based studies or experience, because it tend to just look at parts of Perthes and not get a whole picture. So in terms of prevalence, it affects 1 in 1,200 children, more in boys, as you can see, 1 in 740 boys and 1 in 3,700 girls. This is data from Massachusetts back in 1960, so we don't really know how prevalent it is at this point. And there's some indication that the incidence of Perthes may be decreasing in some countries, whereas it's stable in others. The other important thing to note is it affects very wide age range, basically though almost most of the childhood, age 2 to 14. And so that's where also other confusion comes in, because child presenting at age 3 or 4 is going to be very different from child presenting at age 13 in terms of their development as well as prognosis. There are lots of questions about etiology, and one of the common questions that I get is this passed on and it's unlikely? And this is based on this twin study that was published not too long ago. It's interesting to note that the Danish has this large twin registry, and they looked at Perthes, and in 10 monozygotic twin pairs, there was no concordance. So one of the pair would have the disease, whereas the other didn't. So it doesn't seem like it's hereditary. So this is the important slide about pathophysiology. There's a partial or complete disruption of blood flow, and several studies have shown this using different modalities, and the latest being the perfusion MRI. And as you can see here in the perfusion MRI, there's a complete absence or near complete absence of blood flow to the femoral capital epiphysis compared to the other side. And then there are a limited number of histologic studies that shows, in fact, there is necrosis of the bone, as well as the epiphyseal cartilage, which is consistent with ischemic injury. Okay, next slide. So in terms of pathophysiology, there's also a component of inflammation, and this is present from very early stage. We found in a serial MRIs of these patients over time, it is present even in the very initial stage of the disease, and it persists for 18 months or more. So this is important for managing pain and decrease hip motion. So if we follow a patient from the early stage, what we'll see that there are some radiographic changes as you go from the so-called initial stage to the fragmentation stage. What you see is this further flattening, and then some appearance of osteo or radiolucent areas here, and this one has a metaphyseal changes. And this is sort of a summary of our basic science findings using the Pigment model of osteonecrosis, looking at the histology and pathophysiology of it. So this conceptual drawing represents the normal femoral head with good blood flow. When the blood flow is disrupted, so-called ischemic stage, what happens is the bone dies. And along with that, there's some changes that occur. And these changes include accumulation of microfracture or micro damage in the trabeculae. There is increased calcium content, and this may explain why in the initial stage there's increased radiodensity. Along with that, the epiphysis remains small or stops growing. That's because the growth cartilage around the femoral epiphysis undergoes necrosis. And then with time, it's so-called self-healing disease in a sense that because of the ischemia and hypoxia, there is angiogenesis and revascularization that occur. But important thing is, as the blood vessels come in and bring in repair cells, these cells tend to favor bone resorption, and that's what's shown here with this sort of drawing of osteoclasts, which are resorbing the bone, and the dead bone is not immediately replaced by new bone, but fibrovascular tissue and the new bone formation lags behind. And that's why you see these areas of radiolucency. So to some extent, there is a bone loss and the femoral head is getting weaker with time. So here are the radiographic stages of Perthes described by Dr. Waldenstrom in early 1900s. I call these 4 seasons of Perthes. So stage 1 is the initial stage where there's an increased radial density, and most will have some mild compression, fracture or subchondral fracture of the superior aspect of the epiphysis. And then stage 2 is there's evidence of revascularization and resorption of the bone with leaving these kind of fibrovascular areas of tissue repair. And then over time, there is reossification and the head is healed. So you see that the duration of each stage differs. So the initial stage can last about 6 to 8 months, fragmentation stage about 1 year. But it's important to note that this is when most of the deformity occurs. And then the stage 3 is reossification. This is the longest stage, 3 to 4 years. And then you have healed stage. The other important thing is that not all femoral heads will heal back to a round shape, but end up with this permanent femoral head deformity, as you see here. So more recently, people have moved on to using modified Waldenstrom staging, which divides each stage into early, denoted by letter A, and late, denoted by B. And that's because it provides better idea of where the patient is in terms of the disease process, and it's useful for treatment decision-making and for comparative research. I won't go into details about it. If you are interested in reading this, the reference is right here in JPO 2003. So in terms of conceptual understanding of why the femoral head deform and what is happening, what we see is that there's a weakening of the femoral head. And if we draw the normal side over time in terms of the femoral head strength, this would be sort of increasing as the patient is getting older and heavier. Whereas in the disease side, the femoral head strength is decreasing as the resorption occurs and fragmentation occurs. And then as the reossification kicks in, the strength increases over time. Issue is, this is not only a biological problem, as in abnormal repair process with increased bone resorption versus bone formation. There's also, patient is usually, children are very active. And if their level of activity is higher than what the femoral head could withstand, then that's when deformity would occur. And one of the treatment concepts is to really decrease their activity level, decrease their weight bearing to minimize the deformity. So the deformity is very important because long-term outcome studies, these are retrospective studies, show good correlation with deformity and outcome. And what is shown here are different levels of deformity. So Stolberg 1 and 2 are round head, whereas 3, 4, and 5, as you can see, are ovoid to a more flat to irregular head. And what is noted here as percent is the sign of osteoarthritis at 40-year follow-up. So in the Stolberg 1 and 2, where it's a relatively round head, the osteoarthritis is relatively less compared to a significantly higher levels, as you see here in 3, 4, and 5. So really the goal of treatment is to prevent or minimize the deformity. So going into the making diagnosis, have 4 patients here with evidence of osteonecrosis. And it's important to know that radiographically, there are conditions that can mimic Perthes disease. So for instance, this patient has sickle cell disease. This one to the right has leukemia and treated with chemotherapy that included corticosteroid. This patient has multiple epiphyseal dysplasia, and this one had chronic myelogenous leukemia. So be aware of conditions which can mimic Perthes disease radiographically, and that's why you need a history, physical exam, and along with X-ray correlation to make the diagnosis. So here are lists of diseases that should be excluded before you could call this a Perthes disease. So rule out known causes of osteonecrosis, such as iatrogenic. So that is sometimes when we treat DDH with open or closed reduction, ischemia could be induced that leads to AVN. We all know that steroids is a culprit of osteonecrosis. There are hematologic causes as well as metabolic causes of osteonecrosis. There are also other conditions that could mimic Perthes, such as inflammatory disorder like transient synovitis, rheumatoid arthritis. And one other sort of big group is the skeletal dysplasia, so multiple epiphyseal dysplasia. But usually these patients present with bilateral disease with positive family history. Rarely, septic arthritis could mimic Perthes disease. And I've seen even in major children's hospital that this can be confused and patients end up having acute surgery for arthrotomy and drainage, and then later found to have Perthes and not septic arthritis. So when a patient has bilateral Perthes in quotation, such as this one shown here, we must rule out skeletal dysplasia. We ask for family history. We look at the growth chart to see if there is a short stature that's usually associated with skeletal dysplasia. And if there is question, I usually get limited skeletal survey that includes lateral spine, AP upper extremity, and standing AP of lower extremity. It's important to note that in some patients, the changes are not just due to skeletal dysplasia, but along with that, they also have osteonecrosis or loss of blood flow, which could only be defined through using perfusion MRI. So a lot of times the diagnosis of Perthes is delayed because it has a very insidious onset, pain and limping, and patient continues to play and do sports and do daily activities. So the pain is sometimes exacerbated by these activities, but the next day patient will be wanting to continue with these activities. So that's one of the reasons for delay as well. Children do not describe their pain, location of their pain very clearly, and sometimes they'll complain of knee or thigh pain and not hip pain. And you can see that this patient, a 9-year-old male, would complain of knee pain, and in this patient, they did x-rays, and in some I've seen patient get a MRI of the knee and even arthroscopy, and later found to have a hip pathology. So this is sort of a clinical diagnosis that require a high suspicion to prevent delayed diagnosis. So in terms of treatment-related consideration, as we discussed, the main problem really is the femoral head deformity. So it is one of the most common childhood hip disorders that can produce a permanent deformity of the femoral head, as you can see here in this patient. And then this is shown at skeletal maturity, how the femoral head is really collapsed and deformed. A long-term study, this is from Iowa, that showed at mid-50s, about 40% of patients has already had hip replacement and 10% has severe osteoarthritis, which then means that about half of these patients end up having severe osteoarthritis, whereas half do relatively well. And that's the sort of the issue at childhood. How can we predict who's going to have a good outcome and who's going to have poor outcome, so that in those with poor outcome, we could more aggressively treat these patients. So known prognostic factors to guide treatment decision-making. One of the most consistent prognostic factor is the age at onset of disease, better prognosis in onset before 6, and the lateral pillar involvement at the fragmentation stage of the disease. So you can see this picture here. Perthes disease, very wide age range from 2 to 14. And if you have Perthes at a young age, and there's a lot more room for femoral head growth and remodeling. And as the head remodels, it could round up so that even if it's a relatively severe Perthes, good outcome could be expected. Whereas as the child is older at the onset of disease, then there's less room for femoral head remodeling over time and higher chance of poor prognosis. So in terms of determining lateral pillar involvement, which is one of the other prognostic factor that's been consistently shown to influence the outcome, is this lateral pillar classification, and it's done on an AP X-ray. And what we are looking for is the maximal collapse of the lateral pillar, which is defined by first dividing the epiphysis into three: the central, a half, and then the lateral and medial quarter. And what we're looking at is the height of the intact epiphysis at the medial portion of the lateral column, so right there, in comparison to the affected side. And if there is no loss of height, then it's lateral pillar A. Less than 50% height loss is lateral pillar B. We used to not have BC border, but Dr. Herring, who's the originator of this classification, introduced this as he felt that there are hips that really fall right at the borderline of B and C to improve the prognostication of this classification. And then C is then greater than 50% of the height loss. So here are some example of lateral pillar. So here's A with no collapse, B less than 50% collapse right here. BC is right at the margin of 50%, and then the C is greater than 50% collapse. So one of the strengths of this classification is higher inter-observer agreement than previous classifications, such as Catterall classification. But even then, as you can imagine, a lot of these X-rays, when you classify them, it's not ideal, and there's a room for variability and subjective assessment. So lateral pillar classification typically has inter-observer reliability that ranges from 0.4 to probably about 0.6. The other thing about this classification is that it's based on the degree of femoral head deformity, which means that you have to wait for the almost end of fragmentation stage to accurately apply this classification. And problem with that is when you wait for the deformity to occur, and if the goal of treatment is to prevent the deformity, there's really sort of issue or divergence in terms of your goal versus trying to prognosticate. So going back to the age at onset as the prognosticator, so this study found that in children with onset less than 6, you can see that most treated with symptomatic treatments, which means just basically decreased activity when child's having pain and nothing more than that, that 80% ended up with Stahlberg 1 or 2, which means round femoral head at maturity. So most of these patients under 6 onset of disease could be treated basically just symptomatically without any specific brace or operative treatments. And here's the probability of it based on the lateral pillar group. So most young patients less than 4 at age of onset would have a relatively high probability of having a good outcome. But there are a group of patients between 4 to 6, if they develop lateral pillar B, C, or C, then you can see that the probability is significantly decreased. In terms of the outcome of children with onset after 6 study, there have been a couple of relatively big prospective studies. So these studies included patients over 300 with different treatments. Show that in some patients, femoral osteotomy seems to provide better outcome. So this is an example of femoral osteotomy with the osteotomy fixed by a blade plate. There are also a group of people who do pelvic osteotomy, and the most common one probably is the Salter osteotomy. And so in certain patients, age over 6 seem to benefit by having operative treatment compared to non-operative treatment. But you can see the effect size is relatively modest, meaning that it's not like 100% or 90% of patients who had surgery will do well. So that's why there is further sort of controversy about the consensus of Perthes treatment. Some believe that it's really not enough to subject patients to osteotomy if the outcome is not so high, whereas others believe that it's better than non-operative treatments. So issue is patients who present in an early stage. So as I noted, the lateral pelvic classification cannot be applied in the initial stage. You have to wait till fragmentation stage. So when we just look at the x-rays of these patients with Perthes, it's unclear who would benefit by having treatment and who would not. So here's an example of a patient who has been treated with so-called wait and see approach. Because we're not certain who will benefit and who will not, we will go and basically observe, see patients every 2 to 3 months. And you can see now the head has deformed a little more. And then over time, this patient basically was treated with observation, and it gets to a point where now it's too late to treat this patient, because even with treatment, this patient has poor prognosis. And so this patient was observed over time with so-called wait and see approach, and ended up with a very deformed femoral head with poor prognosis and high risk for developing osteoarthritis. So there's clearly a need to predict the outcome not dependent on femoral head deformity, such as the lateral pelvic classification, to guide treatment decision in the early stage. So this is the proactive approach that we've been advocating. And this is using the gadolinium enhanced MRI with subtraction. So I'm sure you're all aware, we get pre-contrast T1, post-contrast T1, and get a subtraction digitally to get the subtraction image or perfusion MRI. So in terms of the MRIs, the non-contrast MRI, you see the area of necrosis depicted as decreased signal and T1 weighted imaging. And this is due to the lipid degradation, but this is a time-dependent process. You can see the decrease in T1 signal here. Within 3 to 6 months after the symptom starts, in Perthes, has been reported false negative or underestimation of femoral head involvement, and these are the references here. I'll give you an example of one of my patients that I saw for a second opinion. So this patient had left hip pain of 6 months duration. So when they came to see me, parents were interested in knowing what we're gonna do with the left hip. So we got a non-contrast T1 along with the contrast T1. And as you can see, this patient not only had the left femoral head involvement, but also clinically silent the right femoral head involvement. And you can see that was quite extensive. So the discussion, to their surprise, had to be not just about the left hip, but also the right hip. The other thing to notice is that the contrast enhanced MRI shows enhancement of the joint. And you can see, even though this side is not symptomatic, there's evidence of synovial hyperemia. And that's the part of the pathophysiology of Perthes disease, that inflammation starts very early and it tends to be chronic in nature. So we looked at the role of non-contrast versus contrast enhanced MRI in the initial stage of Perthes. This involved 4 independent observers that included 3 pediatric MSK radiologists and myself. And we measured the area of AVN in 30 patients in the initial stage using non-contrast and corresponding contrast enhanced MRI. So here's an example of a non-contrast MRI for observer, and the percentage here represents what they thought the amount of head involvement was. And that this is corresponding MRI with 4 observer being now much tighter and having much higher appreciation of the extent of the involvement. So there was a higher inter-observer agreement with contrast versus non-contrast. And one of the things as a surgeon we like about this method, the subtraction imaging, is that it provides a clear demarcation of the area of involvement on contrast enhanced MRI. So we've also looked at the role of early MRI in the early stage, that's obtained at the early stage in terms of predicting the lateral pillar, which, as I noted, could only be measured in the fragmentation stage. So here's an example of 7-year-old female initial X-ray. It involves a right side here. We got a perfusion MRI, and this patient had relatively good perfusion, and then at 7 months had lateral pillar A. So minimal head collapse. Whereas this patient, you can see the initial X-ray and the perfusion MRI at the early stage showed sort of moderate perfusion, and at 6 months went on to develop lateral pillar B. And then this is an example of a patient who had a more profound hypoperfusion of the epiphysis in the initial stage, and then later found to have a lateral pillar C development. The other thing that we have shown in this relatively small study is that the MRI perfusion quantification correlates with the short term, which defined here as a 2-year follow-up radiographic outcome. So in all patients, if they had a decreased perfusion, so their perfusion index would be lower, they ended up with higher femoral head deformity. Now, this included the patients who were treated with surgery and non-surgery, but if we just looked at the non-operative group, so it's more like the natural history group, you can see that there is even better correlation with less perfusion associated with greater deformity. Here's an example of it. This 7-year-old patient presented at late initial stage, so stage 1B, had a perfusion MRI with very little perfusion of the femoral head, as you can see here on the left side, and later went on to develop, this is a relatively flat femoral head here with high deformity index. So in terms of the perfusion MRI feasibility and safety, we did a retrospective study that involved 5 centers that included, I think, CHOP, Boston Children's, us, and one other center, I think, center from Mexico, that included 165 patients, 298 perfusion MRI studies. We found no serious adverse events, only really side effects were minor sedation, GA-related complications. And in terms of the duration, on average, took about 45 minutes. Most of, or half of these patients just require video goggles or nothing. 1/3 require sedation, and 16% require GA. Patients requiring sedation or GA were generally under 8. And whereas patients over 8 in general, could be done without sedation or GA. I know there's a lot of concern about gadolinium deposition in the brain. At this stage, it's not known whether the gadolinium deposition is harmful or can lead to any adverse health effects. There are 2 types of gadolinium contrast agent, linear versus macrocyclic. I'm sure you are all aware of that. The linear is more unstable and more prone to brain deposition. That's why from the very onset, we've used the macrocyclic gadolinium agents. One that we use is the Deform, which is more stable and less associated with brain deposition based on some study. So in terms of our use of this, because of this information about possible brain deposition, we use perfusion MRI sort of under careful consideration and case by case. So we try not to use this in all patients that we see with Perthes. There has to be a clear clinical indication and benefit. So here are the indication that we use. So this is not, everywhere. This is based on our experience. We use it for 2 main purposes. One is patients over 6 at onset of disease, presenting in the early stage. We are interested in looking at the percent of femoral head perfusion or hypoperfusion, the lateral pillar perfusion, assessment of the synovitis, and assessing femoral head shape, extrusion, and labral sort of pathology. And we generally recommend surgery if greater than 50% of the femoral head is hypoperfused. The other indication is to guide treatment for teenagers using multiple epiphyseal drilling, and we obtain a second MRI to follow up to see if they need repeat drilling. So I'll show you some cases of this and how we use the perfusion MRI. So here's a 7-year-old girl with right hip pain. As you can see here, she's in the initial stage 1B, but the late part of the initial stage. Normally, the so-called wait and see approach would be just to observe this patient and see what happens over time. But that risk is associated with, or that waiting is associated with progression of deformity. So instead of doing that, we get a perfusion MRI. In this patient, there's 80% hypoperfusion, as you can see here. So this patient was then treated with early femoral varus osteotomy, as shown here. One of the benefits about early surgery is you don't have to put as much varus, so not as much angulation to the correction, because the deformity is milder. So this is associated with less limb length discrepancy associated with surgery and less hip abductor weakness. This is follow-up 4 years, and the patient is pain-free and quite functional, and the relatively round femoral head. Here is a case of so-called early stage Perthes, 8-year-old male complaining of left knee pain. And then, as I noted, sometimes kids are not very good at describing exactly where the location of the pain. This X-ray shows that there is some maybe increased radial density, some irregular appearance of the epiphysis. And if you just go by 8, because this patient is over 8, patient will be considered poor prognosis, and some centers will go ahead and do an operation, which in this case would have been completely unnecessary. So we got a perfusion MRI, and you can see the whole head is perfused. So this patient, parents were reassured of what was going on and basically treated symptomatically with good result. Here's an example of one of these patients who were in the original Perthes study group. So this study was initiated in the 80s. This is pre-MRI era. And it's the right side. And one of the hallmark of initial stage of Perthes is that the femoral head, because of the vascular deprivation, should be less. The femoral head size should be less than the normal side. And this patient actually, if you look at it, had a slightly larger femoral head, and this was not recognized. And patient had surgery, whereas this patient really, if they got an MRI, and if it was available at that time, it would have shown a good perfusion, just like our previous case. So it's easy to confuse stage 1 and stage 4 in some cases like that. And patient had surgery and had great outcome, but this probably was completely unnecessary. So now moving on to an example, early stage in older patients. So this is patient over 9, and it's well known that if you are in adolescence, the prognosis of Perthes is poor, and in general, people are more aggressive to treat this with femoral head osteotomy. And we were also, I had this patient booked for femoral head osteotomy, but we obtained perfusion MRI. And what we noticed was that while the central portion had hypoperfusion, the lateral pillar had a very good perfusion. So based on that, we decided to treat patients just with activity modification and non-weight bearing crutches. And this patient did very well, ended up with a round femoral head, plays school football, no complaints. So this patient would have also done well with surgery, but it was, as you can see, not necessary. So perfusion MRI has helped us to individualize treatment. Here's my last case example of a teenager who was treated with multiple epiphyseal drilling. So this is a 13-year-old female cheerleader, left hip pain. in early stage, and you kind of see that here with slight increase in radio density here. So we obtained a perfusion MRI, and you can see a 75% hypoperfused head. One of the things that I like about this perfusion MRI is it's anatomical. So you can see that if you're going to drill this patient, you don't really need to drill the lateral aspect because it already has a good blood flow, and you don't want to disrupt that. So this patient had multiple drilling, 6 to 8 passes using 2mm K-wires, as you can see here. And then we would obtain a follow-up MRI. And this is very informative in that you can see where the drill track was. There's enhancement indicating that some of the blood flow may have come through it. And you can see the base and the medial side of the epiphysis is now perfused. And this patient had second drilling, and eventually most of the head became perfused. And you graphically represent this like that. And over time, you can see that there's increased revascularization with the treatment. So the rate of revascularization was about 9% per month, which is in general higher than what you would expect with sort of non-operative treatment, which is about 5% per month. So this is a patient at 5-year follow-up, age 19. She, last time I saw her, she was in second year in college with no symptoms and doing well. So in summary, Perthes disease is a juvenile form of ischemic osteonecrosis. There's femoral head weakening with 4 sort of characteristic radiographic stages. It's a diagnosis of exclusion, so you must rule out Perthes-like conditions that we discussed. And patients have variable outcome based on prognostic factors such as age at onset, severity of disease, and extent of deformity. And perfusion MRI is useful for treatment decision-making in early stage of the disease. My last slide is one of my patients who was treated for Perthes disease, and you can see that with timely treatment, patient could go back to doing whatever they desire. And in Texas, that's usually bull riding or something very active. So thank you very much for your attention. And I'm happy to answer any questions that you may have.
Harry, thanks so much for that very informative talk. People usually type in questions. So if anyone has questions, they can type in the chat or unmute themselves. Harry, as far as, a lot of the members watching do predominantly adult MSK radiology. Can you comment on your general algorithm for when you obtain perfusion MRI, and as far as follow-up, like at what point do you stop following up using MRI and go predominantly to X-ray?
Yeah, so in terms of management of osteonecrosis or AVN, even in adults, I think X-ray is definitely like the first sort of the line of diagnostic imaging. But I think most centers now go ahead and do a MRI to assess the extent of involvement. The question, really, the controversy is whether you really need a contrast enhanced MRI. In my patients, so I see patients not just with Perthes, but steroid-induced osteonecrosis, typically in teenagers who are being treated with, treated for leukemia. As I also see post-traumatic, so these are femoral neck or femoral head dislocation case in teenagers as well as young adults. So these are patients 18, 19, 20. I would typically get a perfusion MRI because in my experience, it really gives you a clear idea of where the vascularity is. Because if the patient presents at pre-collapse stage or mildly collapsed stage, my goal is to do a minimally invasive procedure such as multiple epiphyseal drilling, along with bone marrow aspirate concentrate injection, which there are some studies, including systematic review, that shows these patients do better, not just with drilling, but adding the bone marrow aspirate. And the reason why I get a perfusion MRI is I get a clear baseline of where the pathology is. And then if I get by getting another MRI 3 to 4 months after, I could then clearly see what the residual area of avascularity is and what the response to the initial treatment was.
Got a question here from Dr. Bordallo. He's asking, do you have any experience with MR angiography or just routine angiography for diagnosis of medial circumflex artery occlusion?
That probably, I do not. Maybe you can answer that question.
Yeah, Marcelo, we don't do a lot of angiography or MR angiography here at Scottish Rite. I know it's a topic of interest and something that's been being studied at research-wise at certain institutions, but it's not a big part of our practice here. The other thing I want to ask you, Harry, we discussed the lateral pillar quite a bit in our conferences here. What's the significance of the lateral pillar? I mean, as far as the prognosis, we talk about how important it is. Is it the biomechanics of the hip? Why the importance assigned to the lateral pillar?
Yeah, so it's sort of, there's some historical, I think, progression of our understanding of Perthes. So when Perthes was sort of discovered and studied back in the 60s and 70s, people had no idea which patients will do well and which will do poorly. And that led to Dr. Cadwell developing his Cadwell classification. But it was found, and that had 4 groups, and it was found that it was very, had a poor inter-observer reliability. And this led to the lateral pillar classification developed by Dr. Herring. And what it showed was that if you, at the so-called fragmentation stage, if you develop lateral pillar B, then your outcome was actually pretty good. Whereas if you develop lateral pillar C, then it was poor. And given the prevalence of X-ray imaging, and those days back in the 80s and maybe even 90s, the MRI was really not used at all, or not very commonly for Perthes. This was like the predominant way to prognosticate and tell parents, how your child is going to do, and also potentially think about how you're going to treat patients. But over time, I think it became recognized that this type of X-ray classification depend on the amount of deformity is not very useful if patient presents weight, and there's really not good to wait for the deformity to occur before you institute treatment. So that's why the MRI methods such as perfusion MRI has been studied and being used more now for prognosticating and treatment decision making in the early stage.
Don't see any other questions in the chat. Harry, thanks so much for joining us today.
Oh, you're welcome. Very welcome. It's my pleasure. And yeah, if you have any further questions, I'm pretty accessible through my email, harry.kim@tsrh.org, and visit our Perthes study group website, perthesdisease.org.
Thank you, Harry.
Okay, bye.